Hello, everyone, and welcome to our module on pulmonary embryology. So before we can talk about pulmonary embryology, let's review a little bit of lung anatomy because this will be relevant when we talk about how the respiratory system forms. So if you look at this cartoon on the slide here, everything sort of above this line is called the upper respiratory tract. This includes things like the nose and the mouth. But everything below this line is the lower respiratory tract, and that includes the trachea, and then all the bronchi and the bronchioles and the alveoli. All those things are part of the lower respiratory tract. So let's start by talking about the trachea, which is this large tube here that feeds air into the lungs. The trachea is surrounded by cartilage. It has these C-shaped pieces of cartilage, and the reason they're C-shaped is because the side where there is no cartilage is where you find the esophagus. The esophagus sits right next to the trachea. So in the trachea, you have these C-shaped cartilage structures. Then when you get to the bronchi are encircled by hyaline cartilage and also smooth muscle. So you find both cartilage and smooth muscle in the bronchi. As the bronchi branch into smaller and smaller vessels, you see less cartilage and more smooth muscle. So very distal bronchi, sort of right before the alveolar sacs, have a lot of smooth muscle and almost no cartilage. Very proximal bronchi, like the main stem bronchi I'm circling here, have lots of cartilage and less smooth muscle. And then finally, the bronchioles, which are the smallest airways, have all smooth muscle, as I just said, and they don't have any cartilage. So there are a couple of different types of bronchioles, those smallest air conducting tubes. So let's talk about that now. So right here, if you see this blue structure, I'm sort of marking with my pen, those are the terminal bronchioles. Those are the last bronchioles before the airways branch into the final respiratory bronchioles that lead into the alveoli. Those terminal bronchioles are the end of the so-called conducting zone. The conducting zone is the portion of the lower respiratory tract and upper respiratory tract that simply conducts air. It does not engage in gas exchange. After the terminal bronchioles, you have the respiratory bronchioles. These are the last bronchioles before the alveolar ducts and the alveoli. And this is the beginning of the respiratory zone where gas exchange is going to occur. Then you have the alveolar ducts, which are shown here in this image. You don't really see them very well. They are small structures that lead into the alveoli. These are small passageways. And then finally, these little bubbles you see here are the alveoli. They contain capillaries, and these are where gas exchange occurs. Oxygen is picked up by the blood and carbon dioxide is released. Okay, let's talk in a little bit more detail about respiratory tract zones. So one way to divide the respiratory system is to divide it into the upper respiratory tract and the lower respiratory tract. And this is something that we often do clinically when we're talking about infections. We talk about upper respiratory tract infections, or URIs, and lower respiratory tract infections, which are things like pneumonia. But another way to divide the respiratory system is into zones. And when you do it that way, the conducting zone refers to the portions of the respiratory system where there's no gas exchange. So this includes things like nose and pharynx and trachea, the primary bronchi, and the large airways. The role of these parts of the respiratory tract is to filter the air, warm and humidify the air, but no gas exchange occurs. And in terms of physiology, these parts of the respiratory tract make up the anatomic dead space, meaning the portions of the respiratory system that hold air but do not conduct gas exchange. And I talk about dead space in a lot more detail in some of the pulmonary physiology videos. Besides the conducting zone, the rest of the respiratory tract is called the respiratory zone. This is where gas exchange occurs. So this includes things like the respiratory bronchioles, the alveolar ducts, and the alveoli. It's said that the respiratory zone contains the lung parenchyma, and the word parenchyma means the functional tissue of an organ. So all these structures here are the functional tissue of the lungs, meaning they carry out the lungs' function of exchanging gas. Okay, so now that we've reviewed some anatomy, let's talk about lung embryology. So the lungs form from an embryologic structure called the lung bud that derives from endoderm. It's an outgrowth of the foregut, which will go on to form the esophagus. If you look at this cartoon on the screen here, this is the foregut, this structure up here between these two lines, and you get little buds coming off of it, and one of those buds is going to be the lung bud that's going to go on to form the lungs. This happens during the 4th week of development. That's when the lung bud forms. It will then give rise to a structure called the respiratory diverticulum. A diverticulum is an outgrowth, and so the lung bud forms the respiratory diverticulum, and then that goes on to develop into the larynx, the trachea, the bronchi, and the lungs. The way the lungs mature into the functioning organ that we all depend on for gas exchange is through a maturation process that involves 5 stages or periods, and we'll talk about each of these in detail. So the first stage is called the embryonic stage. This occurs from 4 to 7 weeks. Remember, the lung bud forms around 4 weeks, so that's the beginning of formation of the respiratory system. So from 4 to 7 weeks, you have the embryonic period, which we'll talk about what that means in a second. That's followed by the pseudoglandular period from 5 to 16 weeks, the canalicular period from 16 to 26 weeks, the saccular period from 26 weeks to birth. And then an important thing to know is that the alveolar period of lung maturation occurs after birth. So at the time a person is born, their lungs are not fully mature, and they will continue to mature through the first 10 or so years of their life. And we'll talk more about that in just a minute. And if you want a handy mnemonic to remember the order of these stages, some people go by every pulmonologist can see alveoli. Okay, so let's zoom in and talk in a little bit more detail about the embryonic period, which, as we just discussed, occurs from 4 to 7 weeks. During this period, you have formations of all the structures of the respiratory system from the trachea to the segmental bronchi. So let's look at my little flowchart here on the screen. So you start with the lung bud, that develops into the respiratory diverticulum and then the trachea. You then get structures called bronchial buds that form, and they develop into the main stem bronchi that supply the left and the right lung. Those bronchi divide into secondary or lobar bronchi, which are going to supply the different lobes of the lung. And then finally, you get tertiary or segmental bronchi, which supply the different segments of the right and left lung. And this is the final structure to form in the embryonic period. And what they're going to want you to know about this period of development in the fetus is that errors during this section of lung development can lead to formation of a tracheoesophageal fistula. So let's talk about that now. So a tracheoesophageal fistula is a congenital anomaly that I talk about a lot in the GI section, but I'll briefly review it here. So remember, the trachea sits right next to the esophagus, and between the two there is a septum that should form to divide the structures. But if that septum doesn't form normally, then you can be left with connections between the trachea and the esophagus. This usually occurs together with esophageal atresia, meaning an underdeveloped esophagus. So let's look at this cartoon on the slide here. This is the most common form of tracheoesophageal fistula. It involves esophageal atresia, meaning the esophagus does not fully develop, and so you can see it stops here, ending in a blind sac. And then you also have a fistula where the distal portion of the trachea is connected to the esophagus that goes down to the stomach. So this is an esophageal atresia, that's this portion right here, together with a distal tracheoesophageal fistula, that's this section right here. And it's the most common form, 84% of cases, of tracheoesophageal fistula. So what are the clinical consequences of this setup? Well, first of all, the esophagus does not connect to the stomach. It ends in a blind sac. This means that as the newborn baby swallows secretions from the mouth, they won't be able to transmit those down to the stomach, so the baby will develop drooling and choking and vomiting. And then classically, a finding is if you try to pass an NG tube into the newborn baby, you can't do that. It can't reach the stomach, and that's because of this blind ending sac of the esophagus right here. The other problem has to do with the fistula between the trachea and the esophagus here. Every time the baby takes in a breath of air, that air goes into the stomach. So the baby develops gastric distension. You can see lots of air in the stomach on chest x-ray. In addition, there can be reflux of stomach contents up through the esophagus here, and those will end up going down the trachea and into the lungs. So the baby can develop aspiration pneumonia and respiratory distress. And so all these features that I've summarized right here are the clinical findings in babies born with this most common form of tracheoesophageal fistula. Okay, now let's move on to the next period of lung maturation, the pseudoglandular period, which occurs from 5 to 16 weeks. It's called pseudoglandular because the lungs resemble a gland at this stage. The lungs are continuing to branch, and they branch all the way down to the level of the terminal bronchioles. Remember, those are the bronchioles right before the respiratory bronchioles. They represent the end of the conducting portion of the respiratory tract. Importantly, during this period from 5 to 16 weeks, there are no respiratory bronchioles or alveoli present. So if a baby is born between 5 and 16 weeks, it's incompatible with life because the baby doesn't have functional lung tissue that can carry out gas exchange. Okay, next let's talk about the canalicular period, which occurs from 16 to 26 weeks. And the word canalicula or canaliculi, if you don't know, means ducts. So in this period, you get formation of very small airways that are like ducts. So what happens in the canalicular period is the terminal bronchioles divide to form respiratory bronchioles, and those respiratory bronchioles divide into very small alveolar ducts. And you can get survival after birth at the very end of this period because when the alveolar ducts form, there can be some alveolar tissue present to conduct gas exchange. And so that's why when we're talking about preterm births, sort of the limit of viability is right around 26 weeks. A baby born around 26 weeks can sometimes survive. Babies born far before 26 weeks usually cannot survive because they don't have alveoli present yet. Other events that occur during the canalicular period include the airway lumens becoming larger so that more air can be conducted in and out of the lungs. And then very importantly, type 2 pneumocytes develop during the canalicular period. These are the cells near the alveoli that produce surfactant, which lowers surface tension and keeps the alveoli open. We're going to talk more about this later, but the formation of these types of cells is critical for survival after birth because babies need surfactant in order to survive. Okay, the next phase of lung maturation is the saccular period. This occurs from 26 weeks to birth, and it's called the saccular period because during this phase, the terminal sacs of the lung, which are the primitive alveoli, begin to form. These sacs are divided by primary septae, but we'll talk later about how more and more walls or septae are going to develop in order to divide and divide and divide these sacs into multiple alveoli. In addition, capillaries develop during this period. They come in contact with the alveoli, and this is how gas exchange can occur. Okay, and then lastly, we have the alveolar period from week 36 until about 10 years of age. So it's called the alveolar period because during this period, the alveoli are maturing. So at birth, it turns out only about a third of the alveoli that will eventually be present in the lungs are present. After birth, there's a slow and steady increase in the number of respiratory bronchioles and alveoli. The major process that's occurring here is septation. Basically, what's happening is large alveoli are being divided by walls or septae into smaller and smaller alveoli, and this increases the surface area for gas exchange. And so this alveolar period, in other words, the process of creating more and more smaller and smaller alveoli, occurs from about 36 weeks of gestation until about 8 to 10 years. Different sources have different numbers for when this process ends. Some say longer than 10 years, some say less, but 8 to 10 years is about when this process is usually complete. So a key term to be familiar with is alveolarization. This is the process that occurs in the lungs during the alveolar period. What's happening is the air spaces are being subdivided. New walls are forming, and those larger terminal sacs are being divided into smaller and smaller alveoli that will eventually become the adult alveoli. This process is called secondary septation. So primary septation, which is when the first walls form, that occurs during the saccular period like we talked about before. During the alveolar period, you get secondary septation, which means additional walls are forming. Those sacs are being divided into smaller and smaller multiple alveoli. That provides more surface area so that in the adult you can maximize gas exchange. And so here's a chart like ones that you can find in many embryology and lung physiology textbooks. It summarizes the entire process of lung maturation from the embryonic phase all the way to the alveolar phase. I won't go through it in detail. This contains all sorts of things that we've already talked about, but you should review this and be familiar with it. This is the kind of information that they're going to test you on in the Step 1 exam. Okay, let's talk briefly about a developmental defect involving the upper respiratory tract, and that's called choanal atresia. So this is a fetal developmental defect, and when it occurs, there's blockage of the posterior nasal cavity opening. I'll talk more about this in a second. The buzzword you want to know is that there's abnormal nasal aperture of the skull. So the aperture is the opening of a structure. So the nasal opening in the bones of the skull is what's abnormal in choanal atresia. And as you can imagine, when you have abnormalities of the skull involving the nasal passages, you can also get other malformations of the midface. And so they commonly occur together with choanal atresia. Choanal atresia is part of the CHARGE syndrome, which is a group of developmental anomalies that often occur together. The C stands for coloboma of the eye, which refers to missing eye tissue. The H is for heart defects. The A is for choanal atresia, which is atresia of the choanae, which are the openings of the nasal pharynx. There's also restricted growth and development. That's the R, genitourinary defects, and ear defects. And so all these things make up the CHARGE syndrome. Choanal atresia is mostly unilateral, but if it's bilateral, that can be an emergency because the openings of both nasal passageways will be blocked. When this happens, a baby will develop noisy breathing and upper airway obstruction signs. There can be cyanosis. It often worsens with feedings because during feedings, the baby can't breathe through the mouth and has to breathe through the nose. It's classically improved with crying, and that's because during crying, there's more breathing through the mouth for the baby. And the diagnosis can be made by imaging. Also, there's inability to pass an NG tube when you try to insert it through the nose down into the stomach. Okay, let's talk about fetal respiration. So in utero, the fetus actually breathes, meaning that the baby aspirates and expels some fluid from the lungs. Even though the lungs are not filled with air, they're filled with fluid. The baby is pulling in and pushing out some of that fluid in utero. The fluid in the lungs is called lung fluid. It's a component of amniotic fluid. It's amniotic fluid made with active transport of chloride into the lung structures. So it's very high in chloride. It's low in things like protein and bicarbonate. It also contains phospholipids, which are important later in development because they help in postnatal lung function. So fetal respiration has two important effects you should know about. One, we sort of already touched on. It stimulates lung development, that movement of fluid into and out of the lungs. It also increases pulmonary vascular resistance by pulling fluid into the lungs. And in utero, pulmonary vascular resistance is very high, and we'll talk more about this at the end of this video. In addition, fetal respiration drives growth of respiratory muscles so that the baby can breathe after it's born. And it's very important for growth of lung tissue during the pseudoglandular phase. This is the phase of lung development we talked about earlier. It's where there's lots of branching of the bronchi going on, and you need fluid movement in and out of the lungs to drive that phase. And you can actually see this on prenatal ultrasounds. If you look at this picture on the screen, you can see in the baby's nose there are some blue and red highlights. That's Doppler signal indicating flow of fluid. And so what's happening is the baby's pulling in fluid through the nose and pushing it back out. That's respiration. Okay, next let's talk about pulmonary hypoplasia, which refers to poorly developed lungs. And as you can imagine, this can occur in preterm births, especially births before 26 weeks, because as we just talked about, that's the period where the lungs are not completely developed yet to the point where they can conduct gas exchange. Besides preterm birth, you can also see pulmonary hypoplasia in some other situations. One of these is in babies born with a congenital diaphragmatic hernia. I talk about this in detail in videos in the GI section, but by way of brief review, this refers to defective formation of an embryologic structure called the pleuroperitoneal membrane, and when this occurs, there will be a hole in the diaphragm, and abdominal organs can herniate up into the thorax and the chest. And if this happens in utero, those organs will take up space inside the developing chest, and that will lead to underdeveloped lungs and pulmonary hypoplasia, and this can be fatal. And so even though this is a GI problem, a diaphragmatic hernia, it actually leads to underdevelopment of the lungs, and that's why it can be fatal. You can also see pulmonary hypoplasia in babies born to mothers who have oligohydramnios, which is decreased amniotic fluid. I talk about this in more detail in the reproductive section, but keep in mind that the fetal kidneys produce amniotic fluid. So if the kidneys are abnormal, that can lead to oligohydramnios, although there are other reasons why it can occur. When renal problems in the fetus lead to oligohydramnios, this is sometimes called Potter's sequence. It refers to the person who first named the sequence. And babies exposed to oligohydramnios from kidney malfunction will develop limb deformities and pulmonary hypoplasia. The limb deformities are because with less amniotic fluid, the limbs don't develop normally and they are compressed. The baby can also have facial abnormalities. And then when there isn't enough amniotic fluid, then there will be pulmonary hypoplasia because as we've been discussing, the baby brings fluid in and out of the lungs so that the lungs develop normally. And when this is caused by fetal kidney anomalies, that's sometimes referred to as Potter sequence. And I talk about this in more detail in the renal section and the reproductive section. So pulmonary hypoplasia is underdevelopment of the lungs, and that can happen to babies that are born prematurely. But another thing that can happen is bronchopulmonary dysplasia. This refers to abnormal growth and development of the bronchi and the pulmonary system. That's why it's called bronchopulmonary dysplasia. This is a complication of premature birth, and it's caused by oxygen toxicity and lung trauma from mechanical ventilation. Premature babies are taken to the NICU, they're administered oxygen therapy, sometimes they're intubated and placed on mechanical ventilation, and these things can damage the developing lung, and that will lead to bronchopulmonary dysplasia. The underlying pathology of bronchopulmonary dysplasia involves alveolarization, that process we talked about earlier. It does not progress normally when babies are exposed to high levels of oxygen and mechanical ventilation. They have less septation. They're born with fewer and larger alveoli because the alveoli don't divide through the process of septation into smaller alveoli, and this leads to a reduced surface for gas exchange. This can be treated by giving surfactant to the baby, and mothers, when they are going to give birth prematurely, are often given steroids antenatally. This helps to trigger the fetus to produce more surfactant as well. The issue with pulmonary dysplasia is after babies progress out of the NICU, later in life they can have respiratory problems during infancy because of the dysplasia. It often improves during childhood, and many children will eventually outgrow it, but babies who are born prematurely can have early in childhood respiratory issues, and that's because of bronchopulmonary dysplasia. Okay, let's talk about bronchogenic cysts. So bronchogenic cysts are caused by abnormal budding of the foregut. We talked earlier about how the foregut gives off the lung bud, but if that process doesn't occur normally, it can leave behind a cyst. These are often found in the mediastinum. They can be an incidental finding if a patient has chest imaging for whatever reason, or they can lead to symptoms like cough and dyspnea. They usually contain clear fluid, and if they become infected, what you will see is some fluid and some air inside the cyst. Importantly, they're cysts, so they're surrounded by tissue. They don't communicate with the lungs. And when you excise these, what you see under the microscope is respiratory epithelium, and it's high yield to know this for your boards. That's what they're going to want you to know about these cysts. So the epithelium will be columnar and ciliated, just like the epithelium you can find in the bronchi. In addition, the walls will contain cartilage, just like you can find in the bronchi. And in fact, this is one of the diagnostic criteria that when you see cartilage, then you know you are looking at a bronchogenic cyst. And often these are asymptomatic or just cause a cough, but occasionally they can lead to more severe problems like pneumonia or compression of the airway. On the bottom right side of the screen are some images of bronchogenic cysts. These are not easy to identify and distinguish from other causes of masses in the chest. They're not going to ask you to do that in your board exam. This is one here on an X-ray. Again, if you're not used to looking at X-rays like a radiologist, this isn't something that's going to jump out at you. Here's one right here on a CT scan as well. In a board question, they're most likely going to have to tell you it's a bronchogenic cyst, or they're going to tell you it's lined with respiratory epithelium and cartilage, and they're going to ask you what it is, and you need to know it's a bronchogenic cyst. Very unlikely they'll expect you to identify it simply based on imaging. And here's another CT scan of a bronchogenic cyst just to give you an idea of what these things can look like. This is a relatively large one at the level of the heart. Okay, let's talk about neonatal respiratory distress syndrome. This is a respiratory condition that occurs in newborn babies, especially when they are born prematurely. The reason this respiratory distress syndrome occurs in these babies is because they're deficient in surfactant. And when you don't have surfactant, there's more surface tension in your alveoli, and this can lead to alveolar collapse. The classic finding on chest X-ray in a newborn baby with respiratory distress syndrome is ground glass in all lung fields. This is an example of what it looks like here. You can see this white patchy material on both sides of the chest in all lung fields. It kind of looks like ground glass, and that's why it's called a ground glass appearance. Some of the risk factors for this condition are shown here. First of all, prematurity is a big one. Babies that are born prematurely do not have enough type 2 pneumocytes in their lungs to produce the surfactant that they need. Diabetes in the mother during pregnancy is also a risk factor. That's because when mothers have diabetes, their blood sugar gets high and they expose the fetus to high blood sugar. This leads to the fetus producing more insulin, and it turns out that insulin inhibits surfactant production. So mothers who have diabetes in pregnancy have a higher risk of having a baby develop the neonatal respiratory distress syndrome. And then lastly, babies born by C-section are at higher risk of this condition. That's because they don't get the stress of vaginal delivery, and so they don't get the surge of glucocorticoids that is normally associated with vaginal delivery. And for this reason, they sometimes can develop this condition because those glucocorticoids coming from the adrenal glands in the baby are helpful to prevent the neonatal respiratory distress syndrome. If you know a baby is going to be born prematurely, or you otherwise think that baby is likely to develop the neonatal respiratory distress syndrome, there are some treatments you can use. First of all, before birth, the mother is given glucocorticoids. That's because these glucocorticoids will cross the placenta and go and affect the baby, and they will trigger production of more surfactant. Also, after the baby is born, you can administer fetal surfactant via endotracheal tube, and this can sometimes prevent or limit the development of respiratory distress syndrome. And if a mother is about to go into labor and you're wondering whether or not the fetal lungs are mature, there is a test you can do on amniotic fluid from the mother to get an idea of the fetal lung development. It's called the ratio of lecithin to sphingomyelin in the amniotic fluid. So you draw a sample of amniotic fluid, you measure the amount of lecithin and the amount of sphingomyelin, and you look at the ratio. If the ratio is greater than 2, then the risk of neonatal respiratory distress syndrome is very low. On the other hand, if the ratio is less than 1.5, this indicates babies at high risk of neonatal respiratory distress syndrome. This is often used in obstetrics when you're trying to decide when to induce a mother to go into labor, but you want to wait until the baby's lungs are mature. You can measure the lecithin to sphingomyelin ratio to determine if the baby has had their lungs mature and that you're at a reasonable point to induce labor. And then when babies develop neonatal respiratory distress syndrome, as I mentioned before, they often go to the NICU, they're given oxygen and sometimes placed on mechanical ventilation. And you should be aware of a couple of complications of therapeutic oxygen in newborn babies. First of all, this can lead to neovascularization of the retina, and the retina can actually detach. This is called retinopathy of prematurity. It's related to therapeutic oxygen use. There's also a condition I talk about in the neurology section called interventricular hemorrhage. Babies who are administered oxygen, newborn babies with respiratory distress syndrome are at higher risk of this complication. And then we already talked about bronchopulmonary dysplasia, but the oxygen and the mechanical ventilation can limit the maturing process to alveolarization of the lungs, and later in childhood, those children can have respiratory problems from bronchopulmonary dysplasia. Okay, I'll finish with one slide talking about pulmonary vascular resistance and how it changes when newborn babies move from the in utero environment to the after birth environment. So in utero, the pulmonary vascular resistance is very high. So remember, blood has to go from the right ventricle to the pulmonary artery, and from there it has to go through the lungs. And if it goes through the lungs, it can get over to the left side of the heart and the left atrium. So this resistance to flow through the lungs is what we call the pulmonary vascular resistance. And it's very high in utero, and there are a couple of reasons for this. One is that in the canalicular stage, like we talked about earlier, there are few or no pulmonary capillaries. So obviously there's going to be tremendous resistance to flow of blood through the lungs. And then in the later stages of pregnancy, even though the lungs may be more developed, there is hypoxemia, and this leads to vasoconstriction in the fetus, just like hypoxemia in an adult leads to vasoconstriction. That's the natural response of the lungs. Blood vessels will vasoconstrict in the setting of hypoxemia. And so the blood coming to the baby through the umbilical vein has a very low PA-SAT of about 30 compared to 90 or 100 or so in the adult. And the O2 sat is only about 80% compared to 98 or 99% in the adult. So you have relative hypoxemia in utero for the baby, and this is going to cause vasoconstriction, and that's another factor that makes the PVR high. And so because it's so hard for blood flow to go through the lungs in utero, only about 10% of the cardiac output goes to the lungs. The rest of the cardiac output bypasses the lungs, going either through the ductus arteriosus or the foramen ovale. And I talk about these things in the embryology videos in the cardiology section. Now, at birth, the PVR falls significantly. The baby takes its first breath of air, the fluid begins to leave the lungs, the oxygen in the lungs goes up, and those vessels stop being vasoconstricted. So at this point in time, you get 100% of the cardiac output through the lungs. And so in terms of basic physiology, what you want to know for your step 1 exam is that in utero, the PVR is high, and at birth, the PVR falls. And then finally, we've talked about pulmonary hypoplasia here, but in babies who have underdeveloped lungs, they have a higher PVR. They have fewer vessels, they oxygenate less well, so they have hypoxic vasoconstriction. And so in babies born with pulmonary hypoplasia, beyond the problems oxygenating their blood, they can have heart problems because their right ventricle isn't able to pump blood through the lungs in the setting of high PVR. And that concludes our module on pulmonary embryology.